All right, the lymphatic system. So, lymphatic system has kind of a twofold thing. People forget the immune system is part of the lymphatic system, and I'll try to explain that as to why it makes sense that this is tied in together and what they're actually doing. So, lymphatic system, one function of it is to remove excess fluid from the interstitium. This fluid passes through the lymph nodes and basically is filtered prior to entering the venous circulation at the subclavian veins on each side. And it's just removing that excess fluid, right? So while we're doing that, we're also performing something called immunosurveillance. So what blood cells in the lymph nodes, specifically lymphocytes, are monitoring this fluid that's passing through and all the debris and picking up anything that could be potentially reactive and immunogenic, meaning an antigen. Antigens are reactive and immunogenic, meaning they're going to create a reaction in their immune system and an immune response. So by removing excess fluid, we're using that to our advantage to some degree of surveilling this fluid that's passing through. And there's a lot more to it than that. So this is the fluid removal part of the lymphatic system. So we can see on the far right here. So these vessels are lymphatic capillaries draining into a lymph vessel here. So here's the interstitial space, here's the plasma, here's a capillary, so here's the arterial end of the capillary, the venous end of the capillary. So blood is moving along this way, right? And we know fluid leaves at the arterial end because there's more hydrostatic pressure, right? That's greater than the osmotic and oncotic pressures combined, so there's more outward force. So you have a net outward force, fluid's going to leave. But in the venous end, well, hydrostatic pressure goes down, so then osmotic and oncotic pressure are greater than hydrostatic pressure, and fluid comes back in. Okay, fluid goes out, fluid comes in, fluid goes out, fluid comes back in. But there's always some fluid that's left behind, right? That's the way I look at it. And we don't want fluid accumulating in the interstitial space because that would lead to what we call edema, right? So these lymphatic vessels take up any extra fluid from the interstitial area. So we talked about causes of edema. Well, one of the causes is obstruction of lymphatic vessels, causing what we would say is lymphedema. So lymphedema. So it's edema due to a lymphatic problem, like obstruction of lymph nodes or lymphatic vessels, or malformations of lymphatic vessels for whatever reason. Okay, or post-surgery, someone had breast cancer, they had an axillary node dissection, removed some lymph nodes. There's some obstructed lymph vessels, and they're going to have some chronic edema that needs dealt with. Okay. So his lymph vessels, they're very thin-walled, they're very low pressure, and they have valves. Sound a lot like veins, but even thinner walled than veins, they don't contain smooth muscle in the walls, right? So even veins, all blood vessels other than capillaries, they have smooth muscle in the wall. Lymphatic vessels or lymph vessels, they don't have smooth muscle. So how do they rely on moving the fluid around? Well, the valves prevent retrograde flow, just like in veins, but there's also muscle contraction. So when our skeletal muscle is contracting, it's going to help push that lymphatic fluid back towards its ultimate draining point, which is going to be the subclavian veins. Okay, so here's my stick figure person. The sticks are really like poorly drawn lymphatic vessels. So this is like the venous system. My venous system is returning blood to the heart. Well, all of these lymphatic vessels are bringing blood up towards, not the heart, but to the subclavian veins. So right subclavian vein, left subclavian vein. So lymphatic fluid's dumping into each subclavian vein, meaning the subclavian veins come together and dump into the superior vena cava, which goes into the heart. Okay, so we're turning this lymph fluid, it's not blood, no blood cells, we're turning this into the venous circulation. Okay, so from the legs, we've got these lymphatic vessels in the lower legs. So there's named areas of aggregations of lymph nodes. There's a ton of them. We don't have to talk about all of them. There's some behind the knee called the popliteal lymph nodes, which makes sense. Some in the groin. These can be palpable even if they're not swollen. And there's no lymphadenopathy. So inguinal lymph nodes. So everything from the lower extremities and some of the trunk drains into this thing called the cistern chyli, where it drains all this lymphatic fluid. So in the thoracic and abdominal regions, there's tons of lymphatics. So we saw on the lungs already, near like the hilum of each lung, there's tons of lymph nodes and lymphatic tissue. The gut, there's a ton there as well as around all your other organs. But especially think of your lungs and your GI system. Well, we're having foreign material come into our body, right, into those body cavities. So we want to have lots of lymphatic tissue there for a reason. We'll talk about that, right? So foreign invaders can be around. So especially in the gut. I think the ileum has the most densely dense area of lymphatic tissue, and we call that the Peyer's patches. So there's even these like we call like a GALT, like gastric associated lymphatic tissue, right? And that's part of like MALT, which is like mucosal associated lymphatic tissue. So anytime there's a mucous membrane, right, because that's a barrier potentially to the external environment, so we want a lot of protection there. All right, so cistern chyli. So the thoracic duct goes to the left, and there's a right thoracic duct that goes to the right. You don't need to know that. And they're going to drain their fluid in these subclavian veins. From the arms, we have lymphatic vessels. There's trochlear or supratrochlear lymph nodes that are in the elbow. Axillary lymph nodes are all through the armpit. So we hear about that a lot when they have breast cancer. So again, when cancer spread, when they metastasize, they can spread two main ways. One is through the blood. The other way is through the lymphatic fluid. So it should also be an important reason why you have an understanding of this. So if there's a tumor or cancer cells in the breast tissue, and the tissue from the breast, that extra fluid normally gets removed and drains into the axillary lymph nodes, which then drain into the subclavian vein. Well, if there's cancer cells that get into the lymphatics, well, they could get into the lymph nodes and they can spread that way. So that's why oftentimes someone has a tumor or cancer, they check the lymph nodes, or called sentinel node biopsy, or doing nodal dissections and removing some lymph nodes and checking them to see if cancer cells have shown up there, right? Which obviously is a bad thing. We don't want that. So head and neck, there's a bunch of lymph nodes. So there's like the auricular lymph nodes, so pre and post auricular lymph nodes are on the ear. Submandibular lymph nodes underneath the mandible, and there's lymph nodes all the way up and down the neck. And then they kind of all drain in this area of lymph nodes right here. I've listed here right above the clavicle called supraclavicular lymph nodes, and then those are going to drain down into the subclavian veins. So why are lymph nodes important? Well, their function is here. So they're doing two very important things. So one, they're cleaning cellular debris, foreign material, and pathogens from fluids. They're cleaning up all the fluid. So one of the main cells they have is called macrophages. So macrophages and lymph nodes, they're cleaning all this stuff up and filtering it and getting rid of any junk, right? But that's not really causing an immune response. So with immunosurveillance, we'll talk about this more on the next couple slides. So as the fluid's coming through, if there's anything that gets picked up that is reactive and immunogenic, that means it's an antigen. Your body's going to respond to it, right? So your body's going to be reactive to it, and it's immunogenic, creating an immune response. So, but the macrophages are just cleaning stuff up. These B and T lymphocytes, so these are the white blood cells, right? The B and T lymphocytes are the white blood cells of the adaptive immune system. So they're checking for potential antigens that are going to activate them, be immunogenic, especially if it's an antigen they've seen before. You have things called memory B cells and memory T cells, and they'll say, oh, we remember this, and they'll respond much more readily. So if you've been vaccinated for something and you've retained that immunity, or you've had the illness before and you've retained that immunity, which you can do for a very, very long period of time, sometimes not very, very long time, and you have an immune response. So when you have an immune response, what happens? We make a bunch more white blood cells, right? And this all proliferates, and that can cause the lymph node to swell. We call that lymphadenopathy, a swollen lymph node. So one of the causes would be due to an infection. So it picks up antigens. Hey, this is an infection of some kind. They can swell. Other reason, cancer cells, like we talked about, because your immune system fights cancer cells as well. So especially T lymphocytes like to fight cancers. So if any cancer cells get into the lymph node, it would cause them to react, have an immune response, and then the lymph nodes would potentially swell up. Okay, and then thirdly, we might see lymphadenopathy if there's obstruction of a lymph vessel. So you might get one swollen lymph node. Why is it swollen? Everyone worries about it. It could just be obstructed for some reason. It might need removed if it's painful. So those are three main reasons. So cancer, infection, and obstruction of lymphatic vessels. Okay, so all these things are going to drain all this lymphatic fluid back into here. So if you did have infection, let's say in your foot, well, you could have lymphadenopathy of popliteal and inguinal lymph nodes. If you had a dental infection or ear infection, you could have, if the ear infection, you might have lymphadenopathy around the ear and the auricular lymph nodes. If it's a dental infection, maybe the submandibular lymph nodes. Maybe even all throughout the neck, you might have, lymphadenopathy there. Same thing with an infection in the arm or the chest, or again, cancer of the breast. You might have swollen lymph nodes or lymphadenopathy of the axillary lymph nodes. So again, this fluid comes into the lymph node through this way. This is called the hilum, which is entering here. This is an efferent vessel, meaning it's coming into the lymph node, right? Because the afferent vessels are bringing lymph lymphatic fluid into the lymph node, and the efferent's taken away. Because remember, afferent always means towards, efferent means away, right? We learned that in the nervous system. So these afferent lymphatic vessels are bringing lymph fluid from the interstitial fluid into the lymph node, right? There's all these areas here full of macrophages, B cells, and T cells, monitoring it, cleaning it, goes to the efferent vessels, and then moves onward, and then eventually back to the subclavian veins. Okay, that's basically how the lymphatic system works as far as removing fluid, right? So again, any obstructions, lymphatic vessels, extra fluids left behind, we get lymphedema. So last two things here. So the thymus. Well, the thymus is pretty active in kids, but not as much as in adults as we age. So all we know blood cells, right? So red blood cells are made in the red bone marrow. Same thing with white blood cells. Same thing with the other ones, the platelets, right? So and they mature in the bone marrow. But the one cell, the T lymphocytes, they will migrate to the thymus and then fully mature in the thymus. That's one separate part or extra part of the lymphatic system you should know. Then this other thing, the spleen. Spleen is pretty important. Spleen's like a giant lymph node, but it has a dual function. We already talked about in the cardiovascular system, although it's not part of the cardiovascular system. Well, the red area of tissue here is called red pulp in the spleen. So that's the part that has the sinusoidal capillaries that take up the old red blood cells. Red blood cells live 90 to 120 days, or if they're damaged, it takes them up, breaks them down, and allows byproducts to be sent via the splenic vein into the portal system to the liver, which we've touched on before, and we'll come back to in the digestive system how that works, right? So all those parts will get shunted off to the portal system. Now the white pulp, this is the immune part. So this is where we have a lot of B lymphocytes and macrophages. Okay, so this is really important for getting rid of red blood cells and fighting infection. So the spleen is really important, especially for fighting encapsulated bacteria. If you lose your spleen, it's not just no big deal. Your liver has to kind of take over helping breaking down some of those red blood cells. But from an immunogenic standpoint, well, what about your immune system, right? Well, your immune system won't be quite as good, and you will be at risk for certain cancers, slightly increased risk for some cancers and infections. That's why if you have a splenectomy, whether it's traumatic or due to splenomegaly for whatever reason, these patients do need extra vaccines before they leave the hospital. The big three, I probably know this, are the pneumococcal vaccine against Streptococcus pneumoniae. So it's usually like the Pneumovax vaccine that you usually don't get until you're like 65 or older. The meningococcal vaccine, so against Neisseria meningitidis, cause of meningococcal meningitis. And thirdly, Haemophilus influenza, so the influenza vaccine. So even if someone's young and healthy, doesn't work in healthcare or anything like that, maybe not an indication to get those vaccines, they would need those, and potentially others. Okay, moving on. All right, so just a recap of like fluid dynamics here, just talking about lymphatics real briefly. So remember, this is the hydrostatic forces moving out, so it's greater at the arterial end and less at the venous end. So on the arterial end, this is overpowering the osmotic and oncotic pressures, which are inward forces. So osmotic pressures based on the osmolarity of the plasma, oncotic pressures based on the protein contact, which is mainly albumin. So on this other side, same thing, osmotic oncotic, but here hydrostatic pressure is lower, so there's going to be hydrostatic out. So here, if outward force is overwhelming inward force, fluid leaves, and the venous end's the opposite's true. The inward force is greater than the outward force, fluid moves back in. Remember, some fluid always left behind, and lymphatic capillaries take it up into lymphatic vessels, then into the lymph nodes, which are causes of edema. Increased hydrostatic pressure, right, to a heart failure and venous insufficiency. So blood is backing up into the alveolar capillaries and left side of heart failure, increases hydrostatic pressure, fluid leaves. Or heart failure passes the right heart down to the legs, or there's bad veins in the legs, so you have venous insufficiency, blood's going to pool, it's going to stretch the veins, increase hydrostatic pressure. So decreased osmotic pressure if you're fluid overloaded with like hypotonic fluid, right? We're going to decrease our osmolarity, we're going to have less inward pull. And then oncotic pressure, so low albumin. This can be due to cirrhosis, right? Because your liver makes albumin and all the proteins. You have nephrotic syndrome, so you're peeing greater than 3.5 grams of protein out every day, so you're losing all this protein in your urine. Or, protein malnutrition, which is kwashiorkor. Can't see it, like kwashiorkor, as opposed to marasmus. Okay, so how does this work? So let's say we're going to start the immune system, right? So how does the immune system work, right? We talked about immunosurveillance and we touched on adaptive things, talking about T cells and B cells. So first part we talk about is the innate immune system. Innate means you're born with it, and innate means immunity is non-specific. So innate immunity includes your barriers, your mechanical barriers like your skin, right, and your mucous membranes. That creates a watertight seal, right, keep out pathogens. We talked about that. So the skin, mucous membranes in the airways, right, the mucous membranes in the GI tract, the mucous membranes in the genitourinary tracts. All those things are exposed to external environment. They're body cavities that are open to the external environment, so we need to have some kind of barriers there. So the mucous membranes produce a thick mucus and try to prevent things from coming in. The epidermis creates that watertight seal over top of it like we want, okay? So that's part of the innate immune system. Next part is, well, inflammation, right? Inflammation is a response usually to tissue injury or hypersensitivity reaction that helps clean up damaged tissue or fight off infection. This can lead to things like a fever response, phagocytosis. All that is going to be part of your innate immune system. Okay, so let's give this scenario here. So we have MRSA, so methicillin-resistant Staphylococcus aureus bacteria. Definitely none of this is to scale. And it breaches through your skin. You had a post-op infection, it got through your surgical incision, and now it's in your tissues and it's damaging cells. So what's going to happen? Well, when there's tissue damage, a couple things happen. So first of all, tissue damage is going to release something from the cell membranes called phospholipids. We know the cell membrane is a phospholipid bilayer. So what can happen is a certain enzyme, which is crossed out here, I'll explain that later, phospholipase A2. Phospholipase is an enzyme that will break down phospholipids into a specific amino acid, or specific fatty acid, arachidonic acid. So it's going to pull a specific fatty acid, in this case arachidonic acid, which is like an inflammatory fatty acid. Why is it inflammatory? Well, it gets further broken down into two pathways. One is the lipoxygenase pathway, which basically the lipoxygenase enzyme converts it into a group of chemicals called leukotrienes. And then the cyclooxygenase pathway, so controlled by the cyclooxygenase enzyme, there's actually two isomers. There's not isomers, two types. There's COX-1 and COX-2, and they form these products called prostaglandins and thromboxanes. What does that have to do with inflammation? Okay, so we rip these phospholipids from the membrane. We break it up down into some fatty acid called arachidonic acid, and then this can be turned into these chemicals here. So leukotrienes, prostaglandins, and thromboxanes. So what happens here, okay? Why would tissue damage want to lead to this? What are we getting at? So the leukotrienes and the prostaglandins, along with histamine, so remember in the skin and tissues we have mast cells that release histamine, response to tissue damage or hypersensitivity reaction. And these things are going to have two main effects on the vasculature. Why do we care about the vasculature? We're getting there. So it's going to lead to vasodilation, so increased blood flow to that area, that specific area of tissues. Okay? And we're going to have increased capillary permeability. So we know the capillaries can't dilate and constrict. They're just one cell layer thick of endothelium. They're for exchange, right? We've been over all that. So if we have vasodilation, more blood is coming into the capillary beds, then we increase the permeability of the capillaries. So what's the point of that? Well, this right here. So these endothelial cells constrict. They constrict and kind of shrink up, and they make these spaces. So in this inferior side, so these endothelial cells are all nicely tightly together. Superiorly here, see there's these spaces, right? It's because of the increased permeability. So you have two types of white blood cells, monocytes and neutrophils. These are non-specific phagocytic white blood cells. So what happens is they're attracted to tissue damage and release of cytokines and all these things that get released in damaged tissue, okay, or due to infection, okay? So because there's these spaces now, they can crawl out this process I'm highlighting here called diapedesis. So white blood cells can't just leave the blood. And if you have an infection or tissue damage and all this debris to clean up, well, if they can't leave the capillaries and get into the tissues from the blood, they can't do anything. So they need to get into the tissue, wherever you're at, whether it's your lung or your skin or your liver, whatever. So because we increase the permeability in these bigger spaces, these can crawl through diapedesis, so the monocytes crawl through here. Once the monocytes get into the tissues, we then call them macrophages. We know there's macrophages living in a lot of tissues already, like the Kupffer cells in the liver and the alveolar macrophages. We know there's dendritic cells in the skin. Neutrophils, same thing, crawl through. So we got neutrophils, and then the monocytes are now deemed macrophages, but they were monocytes, right? And what can they do? They have this fancy thing called phagocytosis, cellular eating. These are the two types of white blood cells, monocytes and neutrophils, that have the ability to perform phagocytosis. So they'll be attracted to foreign material, saying it's foreign to the body. They will engulf it, eat it up, and break it down through phagocytosis. Okay, so they know what's self and what's non-self, and we'll touch on that. Okay, so all this process of these vascular changes are just to get monocytes and neutrophils into the periphery so you can start eating up all these blood cells, or all these all this damaged tissue and pathogens. And it's right there. That's what it sets it up for. Okay, so and then that's what creates the cardinal signs of inflammation. Cardinal signs of inflammation are redness, warmth, swelling, pain, and loss of function, if you want to go through all of them. So we usually say erythema, there's redness or discoloration, there's warmth, it's warm to the touch, put your hand, it's warm, and then edema, which is swelling, right? There could be pain, which is dolor, some people call it dolor, sometimes they used to call warmth calor, so rubor was redness, calor was warmth, dolor was pain, and edema was swelling. I don't think anyone does it that old school anymore. So usually redness, warmth, and edema, or erythema, warmth, and edema is usually how I would put it. Okay, so these vascular changes are what cause those signs, those cardinal signs of inflammation. So take a side step, talk about all these anti-inflammatory drugs. So first of all, why would you want to block inflammation? Inflammation's good in the sense of it's telling your body something's wrong. It's telling your body there's tissue damage, or there could be tissue damage, or it's a hypersensitivity reaction. We think there's tissue damage, and it's telling your immune system, hey, you need to come help us out and fix this, right? So it's a good thing. We don't want to block too much inflammation. Now, if you have an inflammatory arthropathy like rheumatoid arthritis, or you have Crohn's disease, or some other autoimmune disease, well, sometimes your immune system's out of control, inflammation's out of control. We need to do something to regulate that. But after an injury, taking some anti-inflammatory can help with pain, and maybe reduce some swelling if it's restricting mobility to some degree. Okay, but we don't want to overuse these drugs either in the sense of at least a tissue injury. Okay, so the first thing we had was corticosteroids. So the main one people talk about is oral prednisone, right? Oral prednisone, there's methylprednisolone, there's injections of things, and topical creams of like triamcinolone, dexamethasone, all this stuff. So those are deemed corticosteroids. They're based on the hormone cortisone or cortisol that our body makes, which does a few things for maintaining our blood glucose, but it's also anti-inflammatory and immunosuppressive. So we utilize that and made some drugs, okay, that have cortisone or cortisol type effects, as well as some aldosterone type effects. And how does this work in the body? They block the enzyme phospholipase A2. You block phospholipase A2 to some degree, you're going to overall have less leukotrienes, less prostaglandins, and you're going to have less vascular changes. You're going to have less inflammation. Okay, is it healing tissues? No. Is it slowing down tissue damage? No, it's not doing that. Okay, unless you have something like rheumatoid arthritis, where your immune system is literally damaging your body, then that's a different story. Okay, or in the setting of you have a transplant patient who's got a new kidney, and you're suppressing their immune system so they don't reject the kidney they just got. Then if you give them corticosteroids, okay, that makes sense, right? So we're going to reduce the amount of inflammation, which can reduce pain and swelling and all that stuff. So the downside of corticosteroids are you can't take them for very long because they can cause hyperglycemia, insulin resistance, muscle wasting, osteoporosis, mood changes, fluid retention. So the other function of cortisol is what? It's a catabolic hormone. Go to the liver, okay, release some glucose by breaking down glycogen, which is glycogenolysis. Make me take some amino acids from skeletal muscle and go through gluconeogenesis and make more glucose. It's a stress hormone, so you don't want high levels of it from a pharmacological standpoint because it's going to lead to hyperglycemia and over time insulin resistance, which over time lead to type 2 diabetes. It can cause muscle wasting, break down your skeletal muscle tissue, even lead to osteoporosis. Okay, and these also have, psychiatric effects, and if they have aldosterone-genic-like effects, they'll make you hold on to fluid as well. So I came with NSAIDs. NSAIDs, non-steroidal anti-inflammatory drugs. Why are they non-steroidal? Because they're not corticosteroids, right? And cortisol is a steroid hormone. It's derived from cholesterol. They're not steroidal. And they're still anti-inflammatory drugs, but they're not steroidal. There you go. So they block specifically cyclooxygenase, COX-1 and COX-2. And by doing this, they don't have they reduce the amount of prostaglandins, but they don't have any cortisol-like effects or cortisone-like effects. They're not going to affect your blood glucose or anything like that. Okay, they're going to cause insulin resistance. They're not going to cause muscle wasting. They're not going to cause osteoporosis. None of that stuff. Okay, but they're going to reduce a certain degree of inflammation by reducing the amount of prostaglandins you make, right? That's good. That makes sense. Great. Still side effects. So prostaglandins and leukotrienes. They're not just one group of them. There's a bunch of different ones, right? So prostaglandins, well, some of them have these vascular changes for inflammation, but some prostaglandins are protective. You see here on the right, there's certain prostaglandins that protect the stomach lining. There's certain prostaglandins that protect the kidney. So one of the two big side effects of NSAIDs are gastritis or gastric ulcers or gastric bleeding. All bad. It's because you're blocking this protective prostaglandin. The other thing is you can cause acute kidney injury, and then over time it can lead to chronic kidney disease because you're blocking just all prostaglandins to some degree instead of just the specific ones that cause these vascular changes, and we haven't honed in on that yet. Okay. Other issues, thromboxanes. We didn't talk about that. Thromboxanes actually help with platelet aggregation and blood clotting. So when you give NSAIDs, there is an increased bleeding risk because thromboxanes do tie into all the blood clotting and clotting cascades, right? So if you're taking NSAIDs daily, your blood will be a little thinner and you'll be a higher bleeding risk. So if people need surgery, they generally need to stop NSAIDs before surgery. Different NSAIDs have different half-lives, but usually just give you a few days just to make sure it's all good. Okay, so what happens? You have tissue damage, vascular changes, just phagocytosis is going on, you're eating up all these bacteria. Well, what else happens? So all kinds of cytokines get released from this innate immune system. So all this stuff gets released. So what are cytokines? These are little chemicals, okay, they're released from the white blood cells themselves as well as damaged tissues, and they're basically like chemoattractants. They attract more white blood cells to the area, and they go through the whole body and have all these signals and cascades that they start up. So other than calling in more white blood cells to the area, like, hey, we need more help, come in here, they're going to have some more systemic effects. So some examples of cytokines like interleukins, we have interleukin 1, 6, 8, 2, there's a bunch of them. Tumor necrosis factor alpha, there's a bunch of them. Okay, so what some of these things are going to do, well, if you have an infection, well, some of these are going to go to the red bone marrow, and it's going to stimulate the red bone marrow to make more white blood cells. This is called leukocytosis, so increase your white blood cell count. Well, we need more blood cells, especially doing a lot of phagocytosis. We need more neutrophils coming into the area and going through phagocytosis. This process does not stop. Okay. As we go to the liver, it can increase our C-reactive protein. So C-reactive proteins are a really good marker for infection. There's also cardiac-specific CRP, but CRP is a good lab to get to check for signs of infection and systemic inflammation more so. And it's also going to circulate to the hypothalamus, which I made look like a heart. Okay, hypothalamus has our temperature regulatory center there, so sometimes we get these fevers. What's a fever? Well, a fever sometimes can be more or less a good thing. So a fever can make your immune cells work a little more efficiently. May say 5 to 10% more efficient. Just a made-up number I pulled out of my head. Okay, but they're going to increase the set point. So what happens is you're 98.6 degrees, you release all these cytokines. There's other bacteria that can also do this to you directly, so it's not your own body always doing it. So whether it's due to an infection or due to the cytokines released from tissue damage from an infection, well, some of these will travel to the hypothalamus, to the temperature regulatory center, and they'll raise the set point. So I'm 98.6 degrees, my set point goes up to 102. It's at 102 now, okay. What's at 102? Well, I'm still 98.6, so what happens is, well, I'm going to having shivers, right? I'm shivering, and if I'm human, I can put a blanket on, turn my heater up, and I'll shiver to my body temperature, or cover myself up. My body temperature reaches that 102. Then I still feel hot because I'm hotter than I used to feel. You take an antipyretic drug like Tylenol or an NSAID like ibuprofen, right? They're both antipyretic drugs, and then all of a sudden it breaks your fever and your temperature starts coming down. It lowers your set point, and then you're still at 102. Let's say your set point's down to like 99.5. Well, then you're going to sweat, and that's when you quote unquote sweat out a fever. You're sweating like crazy to cool yourself off to get down to the set point. It's all based on the set point in your brain in the hypothalamus. So this is all part of our innate immune system. Okay, lots of phagocytosis, calling in white blood cells, all this stuff. Now, the adaptive immune system. So what are we talking about here? So we already talked about the lymph nodes doing immunosurveillance. Well, what do these monocytes do, these macrophages? So these macrophages, they eat up all this, in this case an infection, bacteria, right, or a virus that would have foreign material on it. They get sucked up into the lymphatic fluid, travel all the way to the next lymph node, and the lymph node, remember that's where we're performing this word here, immunosurveillance. We're checking everything in there. And if something is reactive and immunogenic, your immune system will react to it. And number two, form an immune response to it. So this is where we're looking at all these T cells and B cells. So these lymphocytes, these are the white blood cells of your adaptive immune system, which is a specific and basically learned part of your immune system. Okay, so adaptive immunity. So we usually get this through exposure or vaccination, right? So you have to be exposed to something, and then your body will learn to be immune. Learn to be immune to it. I don't know how to put it, but anyway. So these cells that go in here, so they're called APCs. So any kind of a macrophage or dendritic cell, anything that engulfs something, then it takes part of whatever it engulfed, right, bacteria, virus, whatever, and puts it on its surface through something called MHC2, major histocompatibility complex 2. All of your cells have MHC1, and that's their hall pass to say, like, hey, don't eat me, I'm supposed to be here. And that's why the monocytes and neutrophils and macrophages know not to just start eating your own cells, right, unless you have an autoimmune disorder. And things get all mixed up and screwy. But antigen-presenting cells of MHC2, what they do is they'll eat something up, they'll take something, and they'll put it up on their surface and say, hey, look what I got. Look what I got right here. See this? This is what I found. And they go through the lymph nodes, they're filtering the lymphatic fluid, right? We're going to see if we have a reaction. The T cells and B cells are going to be looking at it and see if they react. So this is my antigen-presenting cell. This was a macrophage. Ate up some MRSA, put a little piece of the MRSA, whatever bacteria, whatever the antigen is. It could be a glycoprotein or just a protein, whatever. As it's passing through here, we see if we respond to it, okay? And if it does create an immune response, this is what happens. We'll activate the B cell pathway, which we call the humoral mediated immune response, and we can activate the other arm of this, so the T cell pathway or the cell mediated immune response. So what the heck happens here? So let's say it activates these. So the B cell pathway or humoral mediated, let's say it's a first time exposure. So these naive B cells, they've never seen this antigen before. So they get converted into things called plasma cells, and then plasma cells make a whole host of immunoglobulins or gamma globulins, whatever you want to call them. So they're proteins that go into your blood. IgG, IgM, IgE, IgA, IgD. So what these things do, they'll travel out into the blood, find the pathogen, and just attach themselves to it. We'll go into more detail about that in a second. Now, cell-mediated pathway, so T cells, let's say if naive T cells never seen this before either, well, they're going to turn into two things. One, T helper cells, or we call them CD4 cells, they're going to help activate these B cells into plasma cells and kind of kickstart this pathway. So they help out the other arm here. And then cytotoxic T cells, they're the ones, the CD8 cells, they go right to the source of the infection. They release enzymes called perforins that perforate or break open the cell membrane or cell wall or whatever, or capsid if it's a virus, and damage it and destroy it. They directly kill it. Cell-mediated means we make these cytotoxic, right? Cytocell, toxic, and go destroy the pathogen. Where the humoral mediated is a little more subtle. We produce all of these antibodies. The antibodies will then attach themselves to the pathogen because they find the specific antigen they bind to them. We'll see the structure of an antibody in the next slide. They do this through neutralization, so they just cover the whole pathogen, so it just basically neutralizes it. Like if it's releasing exotoxin, it'll block it from doing that. Precipitation by making it insoluble in solutions, and then agglutination, just clumping it all up. Close enough. There's something else called complement that can help that out. There's two pathways of this complement system. They basically form this thing called a membrane attack complex that punches holes in like a cell wall or cell membrane of these pathogens, but we're not going to go over all those steps. So the bottom line is these both things can happen at once. Some parts are better than others. T cells are really good at viruses and especially cancers, but they work together. As you can see, T helper cells will help activate the B cell pathway. So this is your adaptive immune response. So the initial response, what happens, it takes a long time, like 5 or 7 to 10 days. You get a spike in IgM first, then IgG, and this is a slow moving process, right? Because these are naive cells, this takes a minute. In the meantime, you can get really, really, really sick. Now, if it's a subsequent response, we form this thing called memory cells. See, memory B cells, memory T cells. So what that means is, we've seen this before, so we'll go through the whole rigmarole, fight off the infection, but then we're going to save memory cells to this, potentially forever, not for hopefully a very long period of time. And they're stored in your lymph nodes. So something comes by, oh, that's that antigen from that virus. I remember that, and you respond much quicker in like 24 to 48 hours, because we'll have memory cells already set it up there. Okay, so what happens is you'll develop plasma cells, release these antibodies. So again, if it's an initial response, you get a spike of IgM, then IgG. Every subsequent responses, you get a big spike of IgG and a little spike of IgM. Those are your main two immunoglobulins you're going to use. The other ones we'll talk about. Okay, and then you can release cytotoxic T cells, and they go and kill stuff. Okay, so what's the point of covering all these things, clumping them up? We can do that, and then in the meantime, we're still going to be doing phagocytosis, neutrophils, and macrophages are still going to be eating stuff up that the antibodies have neutralized, basically. If any of that makes sense. Now, lastly, so here's the 5 immunoglobulins. IgG, it's the most abundant. This actually is transferred from mom to fetus through placental blood. IgM is the second most abundant, so this spikes with IgG in initial and subsequent immune responses, but in the initial response, IgM spikes first. In subsequent responses, IgM spikes second. Do you need to know that? Probably not. IgA is found in body fluids like tears and saliva, and also breast milk. So this is how antibodies are passed from mom to infant through breastfeeding. IgE, this just spikes when we have hypersensitivity reactions, allergic reactions. IgD, we don't really know. Very, very, very little in our body, so we really don't talk about very much. Here's the structure of an antibody. It has these chains on the outside here and here are called heavy chains, and they form this Y structure of the outer part of the antibody, and these two chains in here are called light chains, and between here these are disulfide bonds. So the constant region, so this part of the heavy chain here, and this part of the light chain in here and in here, they're constant, they don't change. But what changes is the ends, the very ends of the heavy chain here, the very end of the light chain in here. They're variable because antibodies bind to specific antigens. So they're the proteins, because antibodies are proteins, the specific amino acids structures there are specific to bind this little antigen, whatever this little antigen is, and it binds here, and it can bind there. Now, the problem with autoimmunity, let's give an example of, say, type 1 diabetes. Well, we think you have a genetic predisposition to it. Then you're exposed to whatever toxins or, let's say, a virus, right, in the environment. And so you get a virus, and then you form antibodies to that virus. Well, then you also form antibodies to the beta cells of your pancreas, and you damage the beta cells, and you stop making insulin. And that's it, right? It destroys your pancreas. Type 1 diabetes is an autoimmune disorder, right? So we think you form antibodies to something else, and they end up cross-reacting with your own beta cells, right? Or you form more antibodies along with it that are for whatever reason. But generally, they're just very specific for a specific antigen, okay? And that's kind of what they look like. So they have to have this very specific variable region to bind a specific antigen. This is them on a bacteria, whatever this is, they just go bind to the antigen on the surface. They can neutralize it. They go through precipitation, clump it up, and then here's a neutrophil with a segmented nucleus, which looks fantastic, and little dots because it's a granulocyte. And it's going to engulf that and phagocytose that. Okay, so this is talking about MHC1 and MHC2. So remember, MHC is major histocompatibility complex. So all cells except red blood cells have MHC1. It's their hall pass. Sometimes we also call it HLA antigens. It's a human leukocyte antigen. And then MHC2 are just on antigen-presenting cells like macrophages or dendritic cells. And an antigen has to be reactive. Your body has to react to it. It doesn't react to it, it's not going to be a good antigen because we're not going to form an antibody to it. It has to be immunogenic. So not only do you have to react, you also have to form an immune response. Okay, last thing, natural versus artificial immunity is also passive and active immunity. So what's natural immunity? Well, you either got antibodies from your mother through the blood, placental blood, or through breast milk. That's natural. You just get, it's not, it isn't creating memory, but you're at least just getting naturally passed immunity, and also just getting sick or exposed to pathogen. Even not symptomatic, but you're exposed to it. Now, artificial would be you didn't get antibodies from your mom, but we gave you antibodies that we made in the lab and given to you in the hospital because you're sick, right? Like recombinant antibodies or whatever, recombinant immunoglobulins, that's artificial. Or we're going to give you a man-made vaccine, and that way you'll form immunity to this virus or infection or this pathogen, because we gave you part of it in a man-made concoction, right? Which is perfectly fine, right? But that's considered artificial. It's what they call artificial. So passive is just giving antibodies. So whether it's a natural way of getting passive immunity from breast milk or placental blood, or artificial way of getting passive immunity is like getting antibodies in the hospital that are recombinant immunoglobulins. Okay. Now, active would mean your body's doing the work. Your adaptive immune system is forming antibodies and forming memories to be immune to something, and that would be something like getting a vaccine or getting sick. That's all I got. So hopefully this helps for the quiz and lymphatic system. Yeah. Any questions? You know what to do.